Good afternoon, everyone. We are pleased to have you join us today for our series of trainings for nursing homes on infection control. My name is Tracy Archibald, and I'm joined by my colleague Angel Davis from CMS to help facilitate this training today. I would also like to welcome and thank our CDC colleagues, Dr. Namali Stone and Dr. Kara Jacobs-Fliska, who are available to help answer questions at the end of the session. A few reminders before we get started. The slides and the recording from today's session will be posted to the QIO program website at www.qioprogram.org. During the open discussion period, please keep in mind that we will get to as many questions and comments as time permits. But if there are any unanswered questions, we will do our best to answer those post-event. It is now my pleasure to introduce our speaker for today, Dr. Jane Peterson from Superior Health Quality Alliance. Dr. Peterson serves as the Chief Medical Quality Officer at Superior Health Quality Alliance and is also a practicing geriatrician with Genevieve, serving individuals living in long-term care settings. She is a past president of the Minnesota State chapters of AGS and AMDA. Dr. Peterson was a 2018-19 Health and Aging Policy Fellow and an APSEC Congressional Fellow, and is an adjunct assistant professor in the Division of Health Policy and Management in the School of Public Health at the University of Minnesota. Dr. Peterson, the floor is yours.
Thank you, Tracy, and thanks to everyone for joining in today. My goal is to provide some practical guidance, whether you're already caring for individuals with COVID-19 or if you're getting ready for your first COVID-19 positive resident. If you want to proceed to the next slide. So this slide describes what I hope to cover today. At the end of the presentation, you should be able to define who should be considered Corona disease 2019, or COVID-19 for short, positive, describe various courses of illness an older individual could take, discuss key aspects of effective management, and describe advanced care planning in the midst of COVID-19. Next slide, please. So let's start out by talking about, so how do we define who is COVID-19 positive? Who falls into this description? I think of it in two basic groups. The first group contains those who had symptoms, were tested, and were found to be positive. Something I want to keep in mind, and I'm going to mention it here, is that as you're looking at published test sensitivities, they're often higher than what we're seeing in real life. So many of the tests that you read about are going to report sensitivities of 90+%, meaning that if you had 10 people who had COVID-19, the test would be positive in at least 9 of them. But in practice, the sensitivity is probably closer to 70%. So this means we might be missing 3 in 10 positive residents. This decrease in sensitivity can be caused by a number of things, such as just when in the course of illness the sample's collected, sample technique, or just even sample degradation between collecting it and its way to the lab. Also in this first group are those individuals who were tested and found to be positive just as the result of screening. They didn't necessarily have symptoms. Then there's another group that really I think we need to also consider in this COVID positive group, and that's those individuals that are presumed positive. So these individuals have symptoms, however, they've been tested and maybe found to be negative, but you just can't, there is no other alternative diagnosis that you see for their symptoms, or maybe they've just not yet been tested, we're waiting on getting the testing, or have been tested and we're waiting for results. One of the comments that one of my colleagues made about testing, and I think it's kind of a good way to think about it, is the current COVID-19 tests, they're kind of like a dull knife. They'll cut, but sometimes you're not always going to get as nice a results as you'd like. So next slide. So on this slide, I wanted to talk about some of the potential courses of illness. And again, I look at this in kind of four buckets. there's a group of people that are COVID positive and have no symptoms. And these individuals kind of basically kind of wait out their illness and kind of graduate, either based on time since diagnosis, or that they are tested negative on one or two or more tests. Then there's a group that maybe has minor symptoms, but they also proceed to recovery, a lot like group 1. Then there's the third group that starts out with either no symptoms or minor symptoms, but then is followed by rapid decline, oftentimes with respiratory or organ failure, and often these are folks that die. The thing is that this decline can be very, very rapid, sometimes even in 24 hours. Then there's a fourth group, and this group is the group that really doesn't have any classic COVID-19 symptoms. So they don't have the classic fever or respiratory symptoms. And they have just kind of this slow progression of disease that includes fatigue, decreased eating and drinking. They may be less alert. This group often also leads to death. And it seems like this group is more common than what we originally recognized. It's really challenging to see this group because oftentimes our screening is looking at more of the classic COVID-19 features, temperature, hypoxia, respiratory symptoms. And if this group isn't showing those, it really reminds us that we need to, while we are doing the kind of classic COVID screening, make sure that we're really looking at that whole person and looking for any changes from baseline that could suggest that they're part of having this slow decline. So next slide. So next I wanted to talk about advanced care planning in the midst of COVID. As you know, advanced care planning is always important, but it really does become crucial in the midst of COVID-19. And one of the most important questions to ask is whether or not that resident or the family would want to be hospitalized if COVID-19 symptoms worsen. And a good way to phrase that is to talk about, how does it align with their goals of care, with hospitalization and what they could do in the hospital, which is really support with mechanical ventilation in line with that person's wishes for quality of life or end of life. So you can see the question of DNR, DNI, which oftentimes tends to be kind of a big piece of our advanced care planning, is really secondary to this question of hospitalization. A couple other things to have as part of this conversation is making sure that residents and families understand that the outcome for hospitalized patients with COVID-19, especially our frail elderly, really isn't good. Oftentimes people die, and it becomes a question of where do they want to die? Do they want to die in the midst of people that they know, that they've been cared for, staff that are familiar to them, or maybe in the hospital with staff that they don't know and their families aren't able to be around? And so I think it's important to be very upfront with that conversation so that both residents and families can make an informed choice. Also, just the low likelihood of survival from CPR in the face of COVID-19 is an important thing that people are aware of. Whatever you decide as a result of your advanced care planning, a really important thing is to make sure you have a process to get this documented quickly. Ideally, this should be done on paper and in the EHR, and this is really because of that group that has that very rapid decline. If a clinician has a discussion on advanced care planning and they write it down in an order and it goes on someplace to get input in the chart and that doesn't happen for however many hours, we could miss that information and not provide treatment that's in line with that resident's wishes. So next slide, please. So this is just kind of a short list of some of the things to look for. We alluded to it in the previous descriptions, but hypoxia, and not just hypoxia, but also increase in O2 requirements. And that would be true for either those residents that are on O2 because of hypoxia due to COVID, or those residents that are on baseline oxygen for some other reason and now all of a sudden having higher oxygen requirements. Increased temperature, as I mentioned before, that just fatigue, change in the level of alertness, decreased intake of food and fluids, also neurological changes. You probably have heard or noticed that, COVID is associated with strokes, CVAs, DVTs. So watching for any neurologic changes could be a sign that they're having hypercoagulability due to COVID. And again, just any significant change from baseline. So the bottom line, don't let classic COVID-19 symptoms bias you. So next slide, please. So as part of management, one of the things the CDC has recommended is increasing monitoring for ill residents, including that assessment of symptoms, vital signs, oxygen saturation by pulse oximetry, and respiratory exam to at least 3 times a day, and that is to help identify and quickly manage change in condition or those folks that are rapidly declining. Also, even those patients that are asymptomatic positive, it is advisable to increase their monitoring from daily to maybe every shift, again, so that you can watch for that rapid decline. Another thing that you want to consider, part of this increased monitoring, giving your staff guidance on how to best access that resident's clinical team in a timely fashion in case that resident does become unstable. I think this is especially important if the resident is followed by a clinical team that does not frequently come into the facility and that maybe your facility doesn't interact with as often. For clinicians you work with frequently, it's also helpful to know how they want to be contacted, because it's possible, they too have set up workflows in their practice around COVID-19 complications. And so you just want to know the best way of communicating with the clinicians so that you can get that information on any change in condition off as quickly as possible and as effectively as possible. This slide also shows a website from the CDC that has a lot of other really good information on what to watch for and how to monitor residents that are COVID-19 positive. Next slide, please. So in this slide, I just wanted to share some of the things to think about to have at the ready. One of the things you may want to consider is creating standing orders for COVID-19. And this may be something you want to work with your medical director on. And things you may want to consider putting in there is just standard use of acetaminophen, how you're going to get and order supplemental oxygen, what you're going to do about discontinuation of non-essential medications, mainly to decrease the number of med passes, and then about whether and how you're going to change nebulizers to metered dose inhalers just to limit the aerosolization of COVID in those residents that are positive. Another thing to have at the ready is some guidance for staff on proning, and I'm going to touch on that on the next slide. But then also just access to comfort medications. Again, because there's that group that can rapidly decline, and because morphine really is the number one choice of treating respiratory distress symptoms, it's good to know how you're going to quickly access morphine for that. And usually it's morphine, the 20 milligram per ml, because you're going to be giving it in small doses and titrating to what the needs of that patient are. So working with your clinicians to figure out how you're going to get access to that quickly so that the resident isn't waiting for those essential comfort medications. Next slide. So proning has been something that's been found to be very helpful in improving breathing and decreasing hypoxia in folks that are COVID positive. This slide shows 2 positions to consider. The one on the left is the fully prone position, where the person is, the bed is flat, they're laying on their stomach, and their head is turned to the side. The other one is the semi-prone position, where one side of their body is propped up on pillows along with some propping under their head and neck. There's a lot of our residents, especially some of our more frail elderly that maybe have real decreased range of motion or have other musculoskeletal issues. The proning can be, full proning can be uncomfortable for. So that's where the semi-proning, may be easier on them. One thing to consider with proning, we're all used to looking for, pressure injury, and we kind of have the common sites that we look for, the coccyx, heels, other bony prominences. We don't often have our patients laying on our stomach, and so now we have to think about, looking at the face and other areas and when people are in the prone position to make sure we're not missing early signs of pressure injury. Next slide, please. Wanted to cover too just some of the challenges due to staffing. And I know in other presentations in this series, we've talked about cohorting and things like that. And when you start to think about that, we're moving residents to different parts of the facility. We're moving staff around depending on, who's working in a COVID positive area and who isn't. And so oftentimes in our facilities, we're using consistent staffing. Well, it's very hard to do that in the midst of cohorting and having people move around. So I think it's really important that we talk about that need for good communication and documentation. One thing you might consider is how to do system-based charting so it's not so dependent on staff knowledge of the resident. You're making sure we talk about, what is their baseline and if there's any change from that baseline so that it's much easier for a new staff coming on that isn't familiar with a resident to assess whether or not there's been a change in condition. Just a quick touch on personal protective equipment or PPE continues to be a challenge in many places. I know we're going to have some other presentations on this topic, but just a couple reminders that, the N95 masks that a lot of us are trying to access and hopefully are able to get and using should be tested to be really effective. There is a difference in N95 masks. There's the KN95, which sometimes is just more available, but they are made to different standards. There are N95 masks with valves on the front that are often what are used in industry. Keep in mind that those protect the wearer, but don't protect those around them. So if you're using the masks with valves, it's a good idea to tape that valve shut so that the person isn't breathing out through that valve. The other thing I wanted to mention is just think of how you might plan for staffing crisis. You may think, gosh, I'm already in a crisis because of all of this, but if really staff ends up down to a minimum, how are we going to manage this? And some of the things to even think about is, what would be that order set for each of these residents that we could really, skinny down to just only the number of essential medications? What are the very key things that we have to do for each resident, just so that we're able to meet everybody's needs if staffing becomes very, very challenging. So next slide, please. This is kind of my grab bag slide, I guess. Other considerations touched on before, that COVID-19, looking for neurologic changes because COVID-19 does seem to be a procoagulant. You may see residents being started on anticoagulation. There is a resource that's included at the end of the slide from AMDA that talks about anticoagulation and provides some things for clinicians to consider. So, like I said, you may see clinicians choosing to prospectively anticoagulate, and that's why they're doing it. Vitamin D, you may also see this prescribed. No clear evidence as to what it does, but I know there are clinicians out there that are prescribing it for their residents. The other one is famotidine. Again, not necessarily clear guidance on that it impacts COVID-19, but you may see clinicians, if they're already on a medication like omeprazole for gastroesophageal reflux disease, you may see clinicians changing them over to famotidine in the chance that it has an impact on COVID-19. The next slide, please. Cardiopulmonary resuscitation, or CPR. There is not real consistent guidance out there, but it's something very important that you have a plan for in your facility. Generally, if you have a COVID-positive resident and that resident has chosen to receive CPR and they have an arrest, limit to 2 staff that both have fit-tested N95 masks with face shields. If you're going to provide ventilation, ambu bag with a HEPA filter to decrease aerosolization, or the other alternative is to not provide ventilation and wait until EMS arrives and they can establish an airway. The thing to consider is staff should not be put at risk. You need to do only what you can safely accomplish. We all want to do what we can to care for our residents, and we all want to do what we can to make sure that we're providing care that's aligned with their wishes, but we have to keep ourselves and staff safe as well. So really the recommendation is to create a protocol for your facility based on what you have for staff, what you have for PPE and other supplies, and the key really is to follow that protocol. If you have a protocol, you need to follow it. And then also making sure that you're communicating that protocol with your residents and their families so that they know if their resident does have a cardiopulmonary arrest and is going to get CPR, what that will involve. So just making sure that you've got that clearly stated and that you're following what you said you're going to do. We started this presentation with what is COVID positive, so we should conclude with what is COVID recovery. Again, the answer is murky and probably will be for a while. I think putting it kind of in 3 buckets. The first is the time-based definition, and that's really for those folks that have tested positive and have remained symptom-free. We have to find some way to say, well, now you can actually go back into kind of graduate from either the COVID unit or wherever they have been or whatever restrictions they've been on. Oftentimes that's 14 to 28 days. Again, look to see what your local guidance is and follow that. The second group is that time and symptom-based definition, and that's for those that have either tested positive and had symptoms or presumed positive due to symptoms. And then the third group is the test-based definition, and that is assuming that that person doesn't have any persistent symptoms, and generally it's at least 2 or more negative tests to say that this person can graduate from being COVID-19 positive. I think keep in mind what I said earlier about testing. It's not perfect. Also, there is a group of people that are challenging because they seem to remain persistently positive long after their first positive test and after symptoms have resolved. This could be due to just residual RNA viral fragments, but that's a challenging group that you'll have to talk with clinicians and maybe look for guidance on. You've also probably heard about or read about the tests that look to see if there's antibodies to the virus. I think we'll continue to hear more about different testing coming out in regard to that. Right now, the tests that are out there, if they do show you have antibody, it's still not clear that provides immunity going forward. You don't get a free pass on COVID-19 necessarily. And even if it does protect, we're still not sure how long it's protected. So a lot yet to learn about this virus. I say it feels like the more we learn, sometimes the less we know. Next slide. So I'd like to thank all of you for listening, and certainly thank you for the care you provide to all of those you serve. I wanted to end with a quote from one of my colleagues. But I just thought was especially appropriate given where we all are during COVID-19 and how all our lives have, I think, felt in many ways a little bit more restricted. But as we think about those that we care for, remember, they once were children or youth that ran through sprinklers and played on sports teams. They once were gainfully employed and contributing to our workforce. They are sons, daughters, moms, dads, aunties, uncles, grandmas, and grandpas with such a wealth of wisdom. Their life has been contracted to congregate living with dependency from independence. Caring for them, it's a privileged and daunting task. And that was from Lois Saprell. She's a nurse practitioner here in Minnesota. So next slide, I think, is just the questions and resources, and I will turn it back to you, Tracy.
Thank you so much, Dr. Peterson, for your great presentation. That was really, really helpful. We are going to now open the Q&A portion of the session, and I am going to turn it to Angel to ask our speakers and colleagues from the CDC our first question.
Thank you, Tracy. Next slide. Right before we move into our open Q&A session, I just wanted to give a couple of reminders regarding the CDC NHSN COVID-19 reporting. So just as a reminder, the CDC does provide recordings of previous trainings posted on their long-term care facility COVID-19 website, which is listed there, especially for those who may feel they need a refresher or was unable to attend the live training. Also, the NHSN Long-Term Care Facility June newsletter will be coming out later this month, so please be on the lookout for the newsletter. And newsletters are posted on the CDC website, and that URL is listed there as well. Next slide. So now we will go ahead and move into our open discussion and questions. So I'm going to start off and give the first question to our CDC colleagues that are on the line. So one of the questions is, if a person tested positive with no symptoms and had all three antibodies and 3 to 7 days later, and then 3 to 7 days later retested as negative, would you still count them as positive? And would you not have retest them in the first place and just consider them positive and keep them isolated for 10 days or symptom-free?
Hi, this is Namali. I think Dr. Peterson sort of alluded to the fact that the serology testing is still something that we're learning about, right? So there are some platforms that I think are quite good. There are some others that are maybe not well vetted and validated yet. So part of the challenge is knowing kind of what is the test you're using and how well tested is it in terms of the sensitivity, specificity, et cetera. I personally would not have retested, or I would just consider them positive and handle them based on the time-based strategy. So yeah, 10 days, monitoring them closely to make sure that they don't go on, right, to develop symptoms, because we know that there are a proportion of people who will test positive before they develop symptoms, and then a couple of days into it, they will develop symptoms. They call them pre-symptomatic instead of asymptomatic. So that's probably how I would approach that. But Jane, do you have any other thoughts for this one?
No, I think you covered everything that I would actually answer on that. Thank you.
Thanks so much, Namali. This question is for Dr. Peterson, and there's two questions that are similar, so I'm going to ask them both together. What is the benefit of placing the resident in the prone position? And then as a follow-up to that, since you're suggesting proning, what are your thoughts on chest PT and postural drainage techniques with COVID-positive patients?
Sure. I'm not a pulmonologist, I'm a geriatrician, but my understanding of why proning seems to work is it allows better aeration of parts of the lungs when they're in the prone position. I'm not sure I can explain the physiology of it, but it just does seem to improve their ability to oxygenate. So if somebody is hypoxic, proning them helps decrease that hypoxia. In regard to the physical therapy, I am going to have to say I have not read much on that and have not seen it done locally. So I might have to turn that one back to see if any of my other colleagues on the phone have a better answer to that one.
Yeah, hey, it's Namali. I'm not sure I can fill that one either, but we could try to do a little bit of looking into that and maybe share some information back if that's something that the folks can help us do.
Yes, we can definitely do that. We'll post that to the website. Thank you. Angel?
Yes. So here's another question, and certainly Namali or Dr. Peterson, you can certainly feel free to jump in. So we have a very interesting case in our nursing home. The individual tested positive back in April and had significant symptoms that have resolved, and he is very well. He has been retested 4 more times and remains positive. Tested for antibodies and has antibodies noted as well. Have you seen anyone like this that recovers clinically, but even after 2.5 months out, still tests positive?
This is Jane. I can go first. Yes, we have. We in my practice, we have that same patient, one of my colleagues, and that's when it is a conundrum. We made the decision that at some point these continued positive tests are probably just due to RNA fragments and that they've actually recovered because we felt at some point we can't, leave the person, either quarantined or in the COVID positive unit forever if they're not converting to negative. I don't know, Namali, did you have any other thoughts on that?
No, I agree with you. This is definitely something we're seeing. It's not frequent. I think we should start with that. Most individuals do clear their viral detection, the PCR positive test, if you will, within 2 to 3 weeks following their resolution, following their onset of illness and after they've resolved their symptoms. There are studies underway to try to understand what the significance is of people who continue to test positive beyond what we would expect into the 4 weeks, 6 weeks, 8 weeks. And I agree with Jane that we've seen that happen. It's there's growing evidence base that would suggest it's unlikely to be transmissible virus. Most of the data that's already available, though, is not in a nursing home resident population. So we have to just think a little bit about whether frailty and comorbidity in the older adult population might change the duration of viral shedding, shifted a little bit longer than you might see in an otherwise healthy adult population. But all that being said, it's unlike, I think it's pretty low probability that somebody that, at that distance of time who's been persistently positive all this time is really shedding transmissible virus. Thanks.
Thank you so much. We have a few questions on the topic of fit testing for N95. Some have asked about whether the seal test is sufficient and if there are challenges with doing the fit testing because of supplies, if there are other recommendations.
Well, this is Jane, and I don't know if we're planning on doing a presentation on this, but it is a big topic. True fit testing of an N95 is you put this apparatus over your head and then try different masks on, and they put some chemical in and decide if you can smell it or not. And that tells you if an N95 is even a good mask fit for you. That is probably way beyond what any facility is able to do regarding the fit testing. So most of the time it is really doing that field testing and having, some really good, visual pictures that staff can look at, not just kind of the written description of how to go about doing that, making sure they're not feeling that they're getting any leaking around the edges of the mask, and so they really understand what that means. The other thing is the making sure we've got often something over the mask, not so much that it helps with the mask, because the N95 is good, keeps us from touching our N95s as well, and that helps them last longer.
Hi, this is Kara. I agree with what Jane was describing, and I just wanted to add also that it definitely is very important, in addition to the fit testing process that she was describing, but just, yes, familiarizing staff. We have been hearing that with supply limitations, there are even different kinds of N95 respirators that are being supplied to facilities, and then those may change with the next batch of supplies that come in. So as best as you are able, trying to help staff, familiarize with the process of putting those on, taking them off, and maintaining those respirators. I also did want to add that our colleagues in NIOSH and I believe also OSHA are working together on trying to create some material for long-term care facilities on the process of developing a respiratory protection program and the process of fit testing, recognizing that it's really challenging right now to try to put these in place, but ultimately the goal is to try to implement something like this within your centers. And so that is something I know that's in the works, and hopefully at some point, maybe in July, there will be a webinar that may be available, which could provide some additional information. Thanks.
Great, thank you so much. This question I'm going to pose to our CDC colleagues. With nursing homes opening back up to allow visitations, how would you recommend visitations for dialysis residents that are still returning to quarantine be handled? Can they have visitors as long as masks are worn and physical distancing is adhered to?
Hey, this is Namali. I'll start, and Kara may have some additional thoughts on this. So let's begin by considering the fact that all facilities are going to be probably at different phases and different points in time with considering how to loosen the visitor restrictions and how to implement some careful and thoughtful reintroduction of families to see their loved ones in long-term care facilities. And I know that this has been a very trying time for everyone, and the strain of being separated from your families during all of this is taking an emotional toll. So we are certainly in favor of being able to facilitate visitation for our residents as long as it's done in a very safe and thoughtful manner. One of the, there are a few considerations, and you are probably very familiar with the CMS guidance on reopening that provides a little bit of information. It's ultimately, we would want you to start by talking with your local health department and ensuring that they know what your plans are and that there's a discussion about, is the prevalence of COVID in the community low? Has the numbers been going down so that there's confidence that the potential for exposure of people going in and coming into your center, the risk of COVID is going down, and we know that there's a strong tie between the prevalence of COVID circulating in a community and the risk to nursing home residents and having COVID introduced into a center. So that's why it's so critically important to know what the local COVID experience is as you're contemplating this change in your restrictions, policies, et cetera. Then, there is guidance on knowing, doing a initial baseline test of residents and staff as part of the reopening process, and that gives you at least a frame for, a point in time, what the COVID exposure or COVID prevalence is in your center, and hopefully there's nothing unexpected identified. There's no new residents or staff detected that you hadn't already known about. So it's assuming that has happened and the prevalence is going down, and the phase of the community has stepped towards sort of phase 2, which is I believe the CMS guidance is that nursing home reopening should be delayed one phase from the community. So if the community's in phase 1, the current restrictions are in place. If a community is able to progress to phase 2 and all of the criteria for that are in place, and a baseline has shown what the COVID experience is in the facility, and there's no new unexpected cases detected, then you could sort of approach how to increase visitation in a measured, thoughtful way. And it's still limited in terms of the hours that you might invite people to come. We would recommend you do it by appointment, that you still limit the number of people that are coming to see any one resident. And so I'm giving you a lot more information than you asked about, which was specifically dialysis. But I think my point of talking through these other considerations is to make the, if the community risk and exposure are going down, that means that for your residents that have to go in and out of the community for things like dialysis, their risk of exposure is also going down. So I don't know that you have to, I think with people who have been placed in, quote, quarantine because you're worried about an unknown exposure, if you look at our guidance, there's language that also points to the prevalence of COVID in the community being part of the consideration as you think about how you are handling new admissions, readmissions, and people who may be going in and out of your center. So I think there may be things changing in the way a center would handle those residents based on the bigger picture of what's happening in their community and their center. Hopefully that helps. It's not a very clear, yes/no answer. I think there's much more complexity in terms of determining if it's safe, and therefore working with public health is a really smart idea. Thanks.
Thanks so much, Damali. We'll start this question with Dr. Peterson. What prophylactic anticoagulant are commonly prescribed for COVID-positive patients? Is aspirin sufficient?
You will see some put on aspirin, but usually it's switching. Usually it's one of the newer injectables. You'll either see, you rarely will see anyone put on warfarin, mainly because we don't want to add the additional INR testing. So it may be most likely one of the newer agents of anticoagulants that are alternatives to warfarin. May see aspirin. Aspirin's a different mechanism. Aspirin's an antiplatelet agent versus an anticoagulant. But it's going to depend, I think, on the clinical situation.
Thank you so much, Dr. Peterson. So this question, I'll pose it to the team, and certainly everyone can chime in that would like. So are nursing home or custodial care patients required to transition to a skilled level of care if COVID-19 positive, if no symptoms, or is it appropriate?
Oh, okay. So, sort of getting at the, it's sort of you have a long stay resident, and now you're almost like an MDS question, right? Do I bump up their level of need based on just the diagnosis of COVID? I think you have to judge the clinical status of that resident, not just the positive test or the detection of the virus, because there are people who have it, and you heard Dr. Peterson talk about how you have so many different clinical courses of residents. Some never get symptoms, others only have mild illness, and then there's a group that will require more medical care and supports and may have more severe infection. So I would assume, and I would also love Jane's thought on this as a clinician, I would assume you would not change their level of care until you had a real need to increase the skilled care being delivered. Jane, is that sounding right to you?
Yeah, it does. I think, and it depends in my mind a little bit on, really how your facility is set up and staffed, and all of those things as well. Because if you have someone who's COVID positive, you need to have them in a place where you've got enough staff to do that level of monitoring. Because like you say, even if they are symptom-free, they can develop symptoms quickly. It's not just but then on top of that, it's also making sure they're in a place where, they're you don't need to put them in a higher level of care just for the COVID positive if you can do the level of testing that's needed in the level of monitoring in a lower level of care. Not sure I added or if I made that more messy, but I think it's kind of there's several things that you're considering, what your facility can do as far as monitoring, and then what the patient needs or the resident needs as far as how much care that they're needing, and you need to balance those two. Plus, it may be, where you've chosen in your facility to cohort COVID positive individuals can play in that too, and that may be just partly what you have available and what area of your building that you can section off depending on your structure.
Thank you so much. This is a question for the team. Do you have any recommendations for discharging a COVID positive resident from a SNF to the home setting?
Jane, do you want to start with some thoughts?
Yeah. And I my guess is, there are, either families that will want to take their loved one home. They need to understand, what that would mean, what they need to do, because they're going to expose themselves to COVID, and how they can provide, what kind of care they need to provide for them. I can't really, in my mind, envision a situation where someone is that needed to be in skilled care that would be going home, that wouldn't be going home with a family. So I think it's really more making sure the family has in place what they need to provide that care, knowing, what they should be doing to protect themselves from acquiring COVID and spreading it. maybe, and it's possible maybe they're going home and they're going to receive hospice services too.
Yeah, I think that's right. I mean, I would just add that wherever somebody is being moved, it has to be a safe environment and the capacity to provide the supports that they need. That could be for somebody who is COVID positive or isn't even. I know that there have been some communities, some families who have wanted to just bring their loved ones out of long-term care facilities, and that's understandable, but it has to be done safely, and they have to be able to provide that level of support. So I agree with you. Thanks.
Yeah, we've seen that people just, I don't want to put my mom or dad or whoever at risk, and we'll take them home, and just making sure that they know where they can access the supports they need.
Great, thank you so much. Tracy, do we still have time for additional questions?
Yeah, Angel, why don't you go ahead and do one more question? Thank you.
Oh, okay. All right, thank you. So I think this is a pretty simple question that anyone can respond to, but it's, is it a reasonable practice to just plan to send COVID-19 patients to the hospital to avoid risk of exposing other residents?
This is Jane, and I can start that one out. I would say no. It may seem like maybe the easiest thing to do, but one of the things that we've tried to do all along is make sure that our hospitals have the capacity to care for those folks that really need the level of care that a hospital can provide. And someone being sent into the hospital just because they're COVID positive and do not have any other symptoms, it's not necessarily true that the hospital would keep them or keep them in the hospital. And so then they may be faced with having to find another facility where they could go to that would accept someone that's COVID positive. I have heard of some facilities that have tried to say, well, if you have to go out to be tested, and if you're positive, you can't come back. I have talked to, at least locally, talked to our ombudsman about that and talked to our Elder Justice League, and that is going to be, it's a hard position to support because, technically it is that resident's home, especially, I know we're talking about nursing home today, but especially if that's an assisted living. So it's best to have in your facility the plans for how you're going to manage someone that's COVID positive and not count on being able to send them to the hospital because they don't necessarily need that level of care. I don't know if anyone else has any thoughts on that one.
Yeah, this is Kara. I wanted to add, it's I think relevant to the question that's being asked, but what we have found is that a lot of the time when you identify one person with COVID or that you're concerned for COVID and you end up finding that they're positive, we have often found others in facilities or centers that have COVID also. And so I think it's, even sending that one individual, to a different setting for that care, you may find that there are already others who were potentially exposed or might even have that infection. And so that, I think I agree, it's important to have a plan for when you do recognize this, how to best care for those residents. And there may be some that do end up needing a higher level of care, but completely agree with what Jane was describing. So important to have a plan and to think about not just that resident, but kind of looking a little bit more broadly to see what else is going on in your facility. Thanks.
Yeah, I agree, because and especially now that we're starting to, more facilities are starting to do, facility-wide screening. it may help get at some of that this may not be the only person that's actually COVID positive in your residents or in your staff members.
Right. And one last thing to add, we know that hospitalization generally is not a good thing for our nursing home residents. They often come back with loss of functionality. Delirium is a big risk when you hospitalize somebody, and the supports and the setup and their other care is not as well provided, I don't think. So just one more reason why we recommend that a nursing home plan for and actually dedicate a space and think through how they would care for COVID positive residents. We don't disagree that you want to move that person out of their current environment and so that a roommate or any other folks on the hall may not be as high at risk. So creating a COVID designated unit in your building that is a space set aside just for caring for COVID positive residents, that is something that we recommend all facilities have thought through and anticipated and planned for. Thanks.
Thank you so much. I want to thank our speaker today, Dr. Jane Peterson, and our colleagues from the CDC, Dr. Manali Stone and Dr. Kara Jacobs-Lifka, for their very thoughtful answers to the questions we've received. We've received a number of questions regarding personal protective equipment, and we encourage you to join us next week on Thursday, June 25th from 4 to 5 p.m. Eastern for our next session, which will be focused on personal protective equipment in the nursing homes. So appreciate your time and attendance today, and have a great evening. And please fill out the SurveyMonkey. Your comments are very valuable to us as we plan future sessions.